start now.
Yeah, ma'am. Thank you. Thank you so much. Yeah.
You're welcome.
Yeah. So, yeah, good evening to all of you. I am Dr. Jeevan Jacob. I am basically coming from the country India. I did my primary medical qualification and post graduation in pharmacology from India. I just passed now the Plab 1 examination. I am very much interested in teaching, and I thank Medin's tutors for giving me this opportunity to present a topic on insulin. So that's about me. And this topic will be covered in around 60 to 70 slides, and I think I will finish it up in 1 hour. And at the end of the session, it will be open for discussion, and questions and concerns will be taken and will be addressed. So the topic for today is about insulin. So I guess all of you will be knowing about insulin by now. You may have studied about insulin in your undergraduation. So it is also an important topic in the Plab examination and also in other international examination. Insulin is a hot topic. So we'll just go through the introduction part of insulin throughout the presentation. We will be addressing the different types of insulins available in the market, how it is acting, the mechanism of action of insulin, and the side effects, how we can manage side effects, and how the insulin is administered to the patients. All those things will be addressed. So as an introduction, we would be just going through the definition of the disease where insulin is mainly used in the management, that is the diabetes mellitus. So this diabetes mellitus is a group of metabolic diseases characterized by hyperglycemia resulting from defects in insulin secretion, insulin action, or both. So here you can see that the hyperglycemia basically means increase in blood sugar levels than the normal ones, and that may be because of problem associated with insulin secretion from the pancreas, or the pancreas may be secreting insulin but it is not able to act properly. That is the problem with insulin action, or maybe combined problem will be there. So this will be the main pathophysiology behind the disease called as diabetes mellitus. So we all know there are different methods to diagnose a case of diabetes in patients nowadays. So the diagnostic criteria we use especially we use the blood glucose level to diagnose diabetes. Also, we have other methods like HbA1c, that is essentially the glycated hemoglobin level, which is also is a standard method for diagnosing diabetes. So if you're checking the fasting plasma glucose in a patient which is having a suspected diabetes, and if it is coming more than that is about yeah, more than or equal to 126 milligram per deciliter, or more than or equal to 7.0 millimole per liter, we will take it as a diagnosis of diabetes mellitus. And we can also use 2-hour oral glucose tolerance test, where we will be giving a 75-gram oral glucose, and after 2 hours, we will be measuring the blood glucose level. And if it is becoming more than 200 milligram percentage or 200 milligram per deciliter, or more than or equal to 11.1 millimole per liter, it is also taken as a diagnostic criteria for diabetes. And if the patient is coming to the clinic or to the doctor, and he is not having any 8-hour fasting, or he is not going for this 2-hour OGTT test or oral glucose tolerance test, we can just look at the random blood glucose level. Along with, we will be assessing whether he is having the classic hyperglycemia symptoms, such as increase in thirst, increase in hunger, increase in frequency of urination. All are the classic features of hyperglycemia. If it is present along with a random blood glucose level more than or equal to 200 milligram per deciliter, then we will take it as a diabetes case. And in HbA1c, normally it is less than 5.6 percentage. If it is more than or equal to 6.5 percentage, we will take it as diabetes. And these are the common diagnostic criteria for diagnosing diabetes. And you can also see that there is a term written there, that is the pre-diabetes. It is a case where the diabetes, the full-fledged diabetes is not manifested yet, but there is chance of developing into a diabetes mellitus case, but they are not normal also. So they are in between the state of normal state and the diabetes mellitus state, and that is called as the pre-diabetes state. And you can also see the values for the fasting plasma glucose, OGTT, RBS, and HbA1c, giving a range of values where you will be falling in the pre-diabetes state. So these are the values where you can use to find out whether the patient is having diabetes or pre-diabetes. And you all know that there are mainly four groups of diabetes as of today. We have the very common type 2 diabetes, and then we have the type 1. Then there is gestational diabetes mellitus and some rare diseases, that is diabetes from other causes. And this type 1 diabetes is, of course, you all know that they are autoimmune diseases, and sometimes the beta cells of islets of Langerhans, where the insulin is produced in the pancreas, is getting destroyed. So that results in type 1 diabetes. And type 2 is essentially a non-autoimmune progressive loss of adequate beta cell insulin secretion, frequently on the background of insulin resistance and metabolic syndrome. So in type 2 diabetes, essentially the problem is with the insulin resistance. That is, insulin is produced by the pancreas, but is not able to act efficiently, properly with the insulin receptors in the cells. So that is the insulin resistance. And but there is chance that the beta cells get destroyed eventually, progressively. In later stage of life, they will be dependent on insulin, which is given from the outside. Then we have the GDM, or the gestational diabetes mellitus, which is detected 24 to 28 weeks of gestation in individuals without previously identified diabetes or high risk of glucose metabolism. So it is the as the name suggests, it is identified in pregnant ladies at 24 to 28 weeks of gestation. Then we have the rare form of diabetes, such as monogenic diabetes syndromes, disease of the exocrine pancreas, and drug or chemical induced diabetes. So this is the classification of diabetes, and you know how the diabetes is diagnosed using the blood glucose and HbA1c levels. Now coming to this just a summary of the same thing that we have discussed. That is the pre-diabetes and diabetes mellitus based on the fasting plasma glucose and two postprandial glucose levels, and we have the type 1, type 2, gestational diabetes, and other specific types. Okay, so our topic proper is about insulins. So what is insulin? So insulin is a hormone produced by the pancreas, by the especially when we specifically we can see that it is produced by the beta cells of islets of Langerhans of pancreas, especially the endocrine pancreas. And this insulin facilitates the uptake of the glucose into the skeletal muscle and adipose tissue by increasing the number of the glucose transporters, especially GLUT4 glucose transporter, that facilitate glucose diffusion into these targeted tissues. They are especially the skeletal muscles and adipose tissue. So that is the function of insulin, and it is produced by the pancreas. And in 1921, it was discovered by Banting and Best, who demonstrated the hypoglycemic action of an extract of pancreas prepared after degeneration of the exocrine part. You all know that pancreas is an organ which is having an exocrine part and some endocrine activity, mainly towards its tail end. And this endocrine activity is mainly by the pancreas is mainly by producing insulin, glucagon, etc. And this insulin was discovered by Banting and Best. And it was first obtained in pure crystalline form in 1926. And the chemical structure was fully worked out in 1956 by Frederick Sanger. So the insulin discovery phase, you see that Charles Best was a fourth-year medical student helping physician Banting, and they together discovered the insulin. And it was tried on one 14-year-old Leonard Thompson, and he was the first patient to receive insulin as a management of diabetes mellitus. And in 1923, the Nobel Prize in Physiology and Medicine was given to Banting and MacLeod. The Banting was kind enough to share half of his prize value to the Charles Best, who was a fourth-year medical student. So that is about the discovery of insulin. Now you can see that insulin structure. It has two polypeptide chain. Insulin is a protein, they are produced by the transcription, and then the mRNA is produced, then it is undergoes translation, and some post-translational modification happens, and our insulin is produced. It is having two polypeptide chain, having 51 amino acids, and having a molecular weight of about 6,000 daltons. The two chains are A chain and B chain. A chain has 21 amino acids, while B chain has 30 amino acids. So you shouldn't confuse between these two. A 21, B 30, and together we have the 51 amino acids. So they are connected, these A chain and B chain, they are connected by two disulfide bridges. Okay, you can see that the yellow lines there connecting the A chain and B chain, there are two disulfide bridges. And if the insulin, after their action, if it is taken inside the cell for destruction, it is with the help of an enzyme called as insulinase, which is a glutathione insulin transhydrogenase enzyme. Glutathione insulin transhydrogenase enzyme. And the half-life of insulin is considered to be 5 to 9 or 5 to 10 minutes, and it is degraded by insulinase, which cleaves the disulfide bond. Inside the pancreatic beta cells, insulin is stored in a complex with zinc ion. So these are the things you can remember about the structure and storage and destruction of insulin. So just going through the biosynthesis of insulin in detail, you can see that insulin is not produced as such. It is produced as a pre-proinsulin initially by the beta cells, and it contains a signal peptide which directs the nascent polypeptide chain to the rough endoplasmic reticulum inside the cell. And in the rough endoplasmic reticulum, this pre-proinsulin is cleaved as the polypeptide is translocated to the lumen of the through the lumen of the rough endoplasmic reticulum and becomes the proinsulin. Now, the proinsulin is then transported to the Golgi apparatus, the trans-Golgi network, where the immature granules are formed. Okay, so initially we have the pre-proinsulin, and then it goes into the rough endoplasmic reticulum and becomes proinsulin. And now the proinsulin undergoes maturation into active insulin through action of cellular endopeptidases known as prohormone convertases, as well as the exoprotease carboxypeptidase E. The endopeptidases cleave at the two position, releasing a fragment known as C peptide and leaving two peptide chains B and A chains. The C peptide is a central portion of the proinsulin. Now, after removal of the C peptide in the Golgi apparatus, the resulting mature insulin is packaged inside the granules, waiting for the metabolic signals and such as leucine, arginine, glucose, mannose, and vagal nerve stimulation to be exocytosed from the cell into the circulation. The hormones are all the hormones. They have to be transported from the endocrine organ into the blood. Through the blood, they reaches their target organs. So that is how the hormone functions. So insulin is also a hormone which starts as a pre-proinsulin, converted to proinsulin, and finally into the mature insulin. And it is released when insulin is released whenever the correct stimulation happens to the beta cells. So this is the biosynthesis of insulin. And as you all know, the central dogma consists of transcription and translation. So there is an insulin gene inside our cell. It is the transcription of this gene results in the mRNA production, which undergoes translation to produce the pre-proinsulin, and as you saw, the pre-proinsulin undergoes the post-translational modification through the rough endoplasmic reticulum and the Golgi apparatus to become our insulin. So that is about the production or the biosynthesis of insulin. Now, now what happens? How is this insulin acting? So effect of insulin on glucose uptake and metabolism. See, you can see that this insulin, when it is released in the bloodstream, it goes through the bloodstream and reaches the target organs, especially the skeletal muscles, adipose tissue, etc. And there, the cells of these organs will be having the insulin receptors on them, and our insulin will come and bind to this insulin receptors, resulting in a cascade of reactions. And finally, from the cell, inside the cell, there is our glucose transporters are present in the cytoplasm. So when the insulin comes and bind to the insulin receptors, certain cascade of reaction happens, glycogen synthesis happens, and this will translocate the glucose transporter 4 into the plasma membrane of this target organ cells, and then the glucose can enter inside these target organs from the blood, and thus the glucose will enter the cell, undergoes glycolysis, and many other processes will be undergoing, and sometimes even the triglyceride synthesis and fat synthesis, ATP synthesis, energy production, everything happens inside the cell. So basically, you can see that the insulin is helping the target organ cells to take the glucose from the blood inside it and undergoes all other mitogenic and metabolic actions. So let us see this insulin receptor in detail. Insulin acts on the specific receptors located on the cell membrane of practically every cell, but they are more seen in the liver, fat, etc. Then the insulin receptors is a tyrosine kinase receptor, which is a heterotetrameric glycoprotein consisting of two extracellular alpha chain, alpha part, and two transmembrane beta subunits linked together by disulfide bonds orienting across the cell membrane as a heterodimer. So you can see from this figure, this is a insulin receptor, which is a receptor tyrosine kinase. It has got extracellular alpha subunit, which is the hormone binding domains. Two of them are there bound together by the disulfide bridges. And then we have the intracellular beta subunit, and they have this ATP binding and the tyrosine kinase activity. The alpha subunits carry the insulin binding sites. Beta subunits have the tyrosine kinase activity. So remember, outside alpha subunit where the insulin comes and binds, and when it binds, the beta subunit gets activated and the tyrosine kinase activity happens. So here the insulin, what happens is that when the insulin comes and binds to this tetrameric insulin receptor, the glucose transport across the cell membrane by the ATP-dependent translocation of the GLUT4 to the plasma membrane happens. The second messenger, phosphoinositol triphosphate, and certain tyrosine phosphorylated guanine nucleotide exchange proteins play crucial roles in insulin-sensitive translocation of GLUT4 transporter from the cytosol to the plasma membrane, especially in the skeletal muscles and adipose tissues. Over a period, insulin also promotes expression of the genes directing the synthesis of GLUT4. So you can see that in simple words, you can see that whenever the insulin comes and binds to the insulin receptors on the cells of the fat and skeletal muscles, it will help in the translocation of the GLUT4 transporter from inside the cytoplasm of that particular cell to the plasma membrane, so that the GLUT4 allows the glucose from the blood to enter the cells, which undergoes glucose utilization, glycogen lipid synthesis, etc. So that is essentially the basic mechanism of the insulin and its action with the help of GLUT4. Genes for many enzymes and carriers are regulated by the insulin through the RAS-RAF and MAP kinase, as well as through the phosphorylation cascade. So let us see a cartoon here, a figure here. See here you can see that the green insulin globule comes and binds to the alpha subunit of the insulin receptor, and the beta subunit gets activated. The tyrosine kinase activation resulting, always remember, the kinase activation is resulting in the subsequent phosphorylation of certain enzymes. Always kinases, activation of these kinases which will subsequently phosphorylate certain enzymes. So in this case, whenever insulin is activating the insulin receptor, the tyrosine kinase activity results in the mitogenic functions and metabolic functions. So insulin essentially have two functions, mitogenic functions and metabolic functions. The mitogenic function is with the help of mitogen activated protein kinase signaling pathway, MAP pathway, mitogen activated protein kinase signaling pathway, resulting in the cell growth and cell expression. So insulin is basically an anabolic hormone. Okay, insulin helps in the cell growth and cell expression. That is the mitogenic function trigger or mitogenic function pathway. Now, insulin is also having metabolic functions trigger where the phosphoinositol 3 phosphate signaling pathway resulting in the synthesis of lipids, proteins, glycogen, cell proliferation. And the main thing is the GLUT4 vesicle being sent back to the cell membrane so that the GLUT4 is available for the extraction of blood glucose into the cells through passive diffusion. And this glucose is sometimes stored as glycogen utilized by the mitochondria to produce ATP, that is the energy. So this is how the insulin helps in the utilization of the blood glucose to produce energy to help in the cell proliferation, cell growth, and gene expression. So did you understand? This is the basic mechanism. Anybody have any doubt in this mechanism of action of insulin? You can just, I am ready to explain it again. Are you okay with this? Everybody understood how the insulin is acting, the mechanism of action? Somebody can respond. Okay, in the chat box, let me see. Okay, all right, all right. Okay, so that is how the insulin's mechanism of action happens. Okay, so let us proceed. Now, after this insulin action, yeah, now the insulin will undergo, its function is completed. Now, what happens? What is the fate of insulin? It can get degraded. The insulin and the insulin receptor can get internalized and is either degraded intracellularly or returned to the surface from the insulin is released extracellularly. The relative preponderance of these two processes differs among these different tissues. Maximum degradation occurs in liver. The liver is the seat of metabolism, so maximum degradation of insulin happens in liver, least in the vascular endothelium. So that is how the insulin is degraded. And insulin, if is given orally, you all know it's a protein. So if it is given orally, it is degraded in the gastrointestinal tract itself. Okay. Injected insulin or that released from the pancreas is metabolized primarily in the liver and to a smaller extent in kidneys and muscles. Nearly half of the insulin entering the portal vein from the pancreas is inactivated in the first pass through the liver. So you may be remembering the basic pharmacology that is called as the first pass metabolism or the pre-systemic metabolism. Any drug that is taken orally, it will get absorbed from the gastrointestinal tract, go through the portal vein, reaches the liver first, and it undergoes metabolism inside the liver. Only the rest of the drug will go into the systemic circulation. So that the rest of the drug that is available for action in the systemic circulation is called as the bioavailability, and it is mainly dependent upon the pre-systemic metabolism or the first pass metabolism happening inside the liver. Normally, liver is exposed to a much higher concentration of insulin than other tissues. During biotransformation, the disulfide bonds are broken and A and B chains are separated and they are further broken down to constituent amino acids. And the half-life of insulin is considered as 5 to 9 minutes. So this is about the fate of insulin. So orally insulin, if it is taken, it is degraded inside the GIT. Injected insulin or the insulin secreted from the pancreas can go into the liver, undergoes metabolism, and can get reduced into constituent amino acids in 5 to 9 minutes after injection. So that is the half-life of insulin. Now coming to the four major categories of insulin, we have the rapid acting, short acting, intermediate acting, long acting, and nowadays we have ultra short acting and ultra long acting insulins also. So basically, we have the rapid, short, intermediate, and long acting insulins, and this is one of classification, kindly a bit of old classification. We will see the newer ones also in subsequent slides. Here we have the Alispro, Aspart, and Glulicin as the rapid-acting insulins. And then we have our own regular or the soluble insulin, which is short-acting. And then we have the NPH insulin or the isophane insulin. It is called as isophane insulin. NPH stands for neutral protamine hegdon, and neutral protamine hegdon, that is the intermediate acting insulin. And we have the glargine detamer as the long acting, and the ultra long acting insulins include degludec, icodec, which is the recent one, and we can see those insulin later. So basically, these are the available insulins in the market, approved ones. These are the Lispro, Aspart, Glulicins, regular insulin, NPH and isophane insulin, glargine, detamer, even the degludec is also approved. Now we can see that see the features of each insulin. Next, in the next slide, we can see that the first one of the rapid acting insulin is the insulin Lispro. How the name Lispro came? Here, B at the B chain, the 28th position we have the lysine, and 29th position we have the prolin. And where usually is the position 28 has prolin and 29 has lysine, it is interchange. It is changed from proline to like proline and lysine is interchanged in the beta B chain of the insulin, normal insulin, to get the Lispro. That is how the name came, the Lispro. Okay, onset of action is in within 15 minutes, and it can the duration of action lasts for 3 to 5 hours. These rapid-acting insulin Lispro, it forms a weak hexamers that dissociate rapidly after subcutaneous injection, resulting in a quick and more defined peak, as well as shorter duration of action. So, since it is a rapid-acting insulin, it will peak very fast. The level of insulin in the blood, it reaches into a peak very fast within 15 minutes. The onset of action starts, and the duration is also the action duration is also very short. It will last only for 3 to 5 hours. So this is how the insulin Lispro acts. Unlike our normal regular insulin, the Lispro needs to be injected immediately before or even after the meal, so that dose can be altered according to the quantity of food consumed. A better control of the mealtime glycemia and lower incidence of late postprandial hypoglycemia have been obtained with the use of the Lispro. So that is the main use of rapid acting insulin. A better control of the mealtime glycemia, mealtime upsurge of blood glucose is controlled properly, and the chance of postprandial hypoglycemia. The hypoglycemia is a dreaded complication of insulin. You all know that insulin and can result in deadly hypoglycemic episodes in patients if it is not used according to the protocol. So that is the postprandial hypoglycemic episodes is less compared to the regular insulin when it comes to the rapid acting Lispro. Using a regimen of 2 to 3 daily mealtime insulin Lispro injections, a slightly greater reduction of HbA1c compared to the regular insulin has been reported in studies. And of course, fewer hypoglycemic episodes occurred. Lispro, Aspart, Glulicin. These are the rapid-acting insulin. Lispro, Aspart, and Glulicin. Here, in Aspart, the proline at the B28 of human insulin is replaced by aspartic acid amino acid. This change reduces the tendency for self-aggregation, and the time action profile is similar to the insulin Lispro. It more closely mimics the physiological insulin release pattern after a meal, with the same advantages as insulin Lispro. Onset is 15 minutes and action is 3 to 5 minutes. In glulicin, another rapidly acting insulin analog with the lysine replacing asparagine at B23 and glutamic acid replacing lysine at B29. Thus, the name the glulicin came into being. Properties and advantages are similar to insulin Lispro. It has been, this glulicin is, remember this point, it has been particularly used for the insulin infusion pump, continuous subcutaneous insulin infusion pump, CSII. Okay, continuous subcutaneous insulin infusion pump. So glulicin, remember, glulicin is preferred in pumps. Now our regular insulin, that is a short-acting insulin, it is the only insulin that is approved to be administered via intravenous route. We may use some insulin analogs also off label, but this one is the approved one. And it comes from the porcine or the pork and beef or bovine or human pancreas, or genetically engineered using the recombinant DNA technology from certain microorganisms. First one was E. coli. So remember, initially this insulin, our regular insulin, was taken from the uh, porcine source, sometimes the beef source, and even in the human, from the human pancreas also it was taken. But later on, this recombinant DNA technology using the E. coli, it revolutionized the mechanism of synthesis of short-acting insulin, regular insulin. Onset is within 60 minutes, and it can last for 6 to 8 hours. Intermediate acting insulin is isophane insulin or the neutral protamine hectone insulin. That is the NPH. And remember, NPH stands for neutral protamine hectone. A sterile suspension of zinc insulin crystals and protamine sulfate, a protein from the obtained from the sperm of a fish known as the Oncorhynchus family Salmonidae, and that is insulin suspension is called as insulin zinc suspension is called as the isophane insulin or the NPH insulin. Onset happens in 1 to 2 hours, and duration can last up to 24 hours. So these are the intermediate acting insulin. Insulin zinc suspension, a sterile suspension of insulin modified by the addition of zinc chloride, has an advantage of fewer allergic reactions than NPH. This is another, Lente insulin is another example for the intermediate acting insulin. And onset is 1 to 2 hours, and duration is 10 to 16 hours. Or remember, insulin zinc suspension or the Lente insulin is another example for intermediate acting insulin, other than we have the NPH, that is a neutral protamine hectone or the isophane. So we have two examples now with us: insulin zinc suspension, the Lente insulin, and neutral protamine hectone for intermediate acting insulin. And the famous long-acting insulin is glargine. This long-acting biosynthetic insulin has two additional arginine residues at the carboxy terminus of the B chain, and glycine replaces asparagine at A21. The classic features you should capture from the slide is the pH. It remains soluble at acidic pH, but precipitates at neutral pH on subcutaneous injection. So remember this point, very important about glargine, which is a long-acting insulin. It remains soluble at pH 4 of the formulation, but precipitates at neutral pH on subcutaneous injection. Also, after a depot is created from the subcutaneous injection, which monomeric insulin dissociates slowly to enter the circulation. So, whenever you give a subcutaneous injection of glargine, initially they form a depot there, and slowly they will be released into the blood circulation. Onset of action is delayed, but relatively low blood levels of insulin are maintained for up to 24 hours. So you can see that from this depot, slowly this insulin from this subcutaneous depot is released into the blood circulation, so that the release of insulin is very slow. That means they can act for a long period of time. That is why it is called as a long-acting insulin. It can act more than or almost up to 24 hours. You remember, since this release from the depot in the subcutaneous tissue into the blood vessel happens very slowly, and that it's a smooth release. A sudden rise of insulin level in the blood is not happening. That is why it is called as a peakless insulin. Okay, insulin glargine is called as a. So remember this point also. Insulin glargine, it is active at the, it is stable at the pH 4 or acidic pH. It is having a peakless action, that is a smooth peakless effect is obtained when it is given subcutaneously, and it is suitable for once daily injection to provide background action or background insulin action. You will understand this when you are practicing. You will see you may be giving the patient the basal bolus regimen, where the bolus is a short acting or the ultra short acting, rapid acting insulin may be given during the meal time, whereas the basal insulin, which is the glargine insulin, will be given at the night time, so that it will maintain the blood insulin levels during the night time, and it will prevent hyperglycemia in the patient. Fasting and interdigestive blood glucose levels are effectively lowered irrespective of the time of the day when injected or the site of subcutaneous injection. But our glargine is mostly injected at the bedtime in the night. So there is lower incidence of the nighttime hypos and compared to the isophane or the NPH insulin. See, usually before the glargine, the basal bolus regimen, when the doctors use this regular insulin or the rapid acting insulin as the bolus regimen, and as a basal insulin they use NPH or the intermediate acting insulin. Later on, the glargine was discovered and developed, and that glargine lowered the incidence of the nighttime hypoglycemic episodes, because with the NPH, the problem was that whenever the patient was given NPH in the night, sometimes later on in the night, the patient developed hypoglycemia. So that's a very dangerous condition. So that problem was decreased with the introduction of glargine. So lower incidence of nighttime hypoglycemic episodes compared to the isoflurane has been reported with glargine. However, it does not control the mealtime glycemia. For that, we require the rapid acting insulin or the oral hypoglycemic agents. Nowadays, we don't use the term oral hypoglycemic agents. We use the term oral anti-diabetic agents, which is used concurrently. Because of acidic pH, it cannot be mixed with any other insulin preparation. Must be injected separately. Remember that pH 4. Do you remember that? So the glargine is stable at acidic pH, and other insulins are having the neutral or the basic pH, so it cannot be mixed with the other insulin preparation, and this glargine must be injected separately. It shouldn't be mixed with the other insulins in the same syringe. So that is a very important point, practical point, and also the important point in your examinations. We have the glargine onset is 2 hours, and up to 24 hours it can last. Then we have ultra lente. It is an extended insulin sink suspension. We have the lente, the insulin sink suspension, which was an intermediate acting. The sterile suspension of this insulin modified by addition of zinc chloride made this insulin sink suspension as an extended insulin sink suspension called as ultra lente. That is also an example for long acting insulin. Determer is a myristoyl fatty acid radical attached to the amino acid lysine at D29 of our classical insulin chain. As a result, it binds to the albumin after subcutaneous injection, from which the free form becomes available slowly. So it makes it a long-acting insulin determer. A pattern of insulin action almost similar to that of glargine is obtained, but twice daily dosing may be needed in case of determer. Duration can last up to 24 hours in case of tetramer. So myristoyl, a fatty acid radical, is attached to the amino acid group of lysine. So we have the glargine, determer, extended insulin sink suspension, or the ultra lente as examples for long-acting insulins, and then came the degludec. Degludec is a new generation ultra long-acting basal insulin. When injected into the subcutaneous tissue, self-association and formation of the multi-hexameric chains occur at the injection site. The formation of the multi-hexameric chain is a principal mechanism of protraction. What's the protraction? Long duration of action of degludec is attributed to this multi-hexameric chain production when it is injected subcutaneously. We will see that how this is happening. When injected into the subcutaneous tissue, the insulin self-associate, the insulin molecules will associate together to form multi-hexameric chains at the injection site, and they are released slowly into the blood, and that helps in the long duration of action of degludec. The insulin molecule slowly dissociates and enters the circulation as monomers. Reversible binding to the albumin contributes further to the mechanism of protraction or long duration of action. The result is a long, flat, and extended insulin profile as shown in the following slides. You can see here when the degludec, okay, you can see the during the x-axis you have the molecular size, and in the y-axis you have the duration of action. Now, whenever the degludec is injected, initially they are injected in the form of monomers, but inside the subcutaneous tissue, it forms a dihexamer. Initially, they form the hexamer, then combine together from dihexamers, and they again combine all together to form the multi-hexamers, which is staying there inside the subcutaneous area, and slowly they will get released into the blood circulation, and that makes it a long-acting insulin, ultra long-acting insulin, insulin degludec. So we can see a cartoon here, the insulin degludec. The mechanism of protraction is shown as a cartoon here. It is injected into the subcutaneous tissue, and it is initially in the form of monomers, then form the hexamers, dihexamers, and slowly they form the multi-hexamers, and they stay inside the subcutaneous tissue, and later on they will get released into the capillary blood, where they get bound to the gray substances called as the albumins, and they will get transported through the blood as an albumin bound form, albumin bound insulin degludec. And when they reach the insulin receptors, the insulin is released from the albumin. They gets bind to the insulin receptors in the cell membranes of the target organs, and the action happens. Okay, so you can see here where the insulin degludec, when it is injected into the subcutaneous tissue, it forms the multi-hexamers, and inside the subcutaneous tissue, and later on it is released into the capillary blood, where it get binds to the albumin, and later on reaches the insulin receptors. It is released from the albumin, and the action happens. So that is the insulin degludec. Now we have icodec. This icodec is like, it can be given weekly. It's considered as a weekly insulin. It's a ultra long acting insulin. Okay, insulin icodec. It is not approved by the FDA yet, but maybe getting approval towards the end of this year. And it is approved in certain European countries, Canada, etc., for the management of type 1 and type 2 diabetes, especially for the type 2 diabetes. It's a long-acting basal insulin analog, insulin icodec. It can be given once weekly subcutaneously. The molecular modifications underlying the longer half-life of icodec is attributed to the 3 amino acid substitutions, preventing enzymatic degradation, ensure stability and solubility. Addition of C20 fatty acid imparts strong and reversible albumin binding, and all modifications contribute to slow receptor-mediated clearance. Icodec interacts with insulin receptors to activate the same signaling pathways, which we have seen in the previous slides, to get the action of insulin. Icodec does not demonstrate increase in the binding to the IGF receptor and has low mitogenic potency. Gradual continuous release of icodec from the albumin-bound depot really leads to the prolonged action. Now we have certain other forms of insulin. So we have already seen the the short acting, rapid acting insulins, short acting insulins, intermediate acting insulins, long acting insulins, and ultra long acting insulins. Okay, so okay guys, so are you okay with this classification of insulins, which is given by injection, rapid acting, short acting, intermediate acting, long acting, and ultra long acting degludec and icodec? Are you okay? Comment. You can comment in the comment box. Yeah. Any doubts? Everybody okay with the classification? Don't worry. Don't worry about the detailed mechanisms. Just remember the catchy points. They are important for your examination, even for the practical purposes also. Always in the slides, you have to catch the particular important high yield points. Okay. Right. Right. Okay, so now we have certain other forms of insulins. They are, one of them is the Exubera. Exubera is a inhaled form of insulin, was approved in 2006 by FDA. Inhalation powder is a white to off-white powder in a unit dose blister. Exubera delivers insulin by oral inhalation. The onset of glucose lowering activity is in 10 to 20 minutes, and duration of action is 6 hours. Can be given in children and old age population, but it was discontinued later because of certain side effects. That is about Exubera. But later on, you can see that later, there was another inhaled form of human insulin approved by the FDA on June 27, 2014. That is Afreeza. Afreeza is an inhaled human insulin. Combination drug devices product human insulin produced by the recombinant DNA technology is used in Afreeza, used as Afreeza. And insulin is dissolved into the carrier particles, dry powder, and packed in cartridges and dispersed through the inhaler, just like our inhalers used in the management of asthma. We use this inhaled insulin in the management of diabetes. Recombinant regular human insulin lowers the blood glucose levels by stimulating the peripheral glucose receptors. You know the mechanism already. So this is Afresa. Its pharmacokinetics of Afresa, you can see the absorption, distribution, metabolism, and excretion constitutes the pharmacokinetics. So it is absorbed. The F stands for bioavailability. Remember, the inhaled insulin, it has 37% bioavailability compared to the subcutaneously administered regular human insulin. VD stands for the volume of distribution. It is 0.26 to 0.36 liter per kilogram. Metabolism is same as our insulin, endogenous insulin. And the excretion, any swallowed insulin is degraded and eliminated unchanged in feces. And it happens, the total elimination period is about 1 to 180 minutes for Afresa, which is the inhaled insulin. Now, it is indicated for pre-mealtime rapid insulin delivery for type 1, type 2 diabetes, must be used in combination with long-acting agent for patients with type 1 diabetes. You know, patients type 1 diabetes are totally dependent upon insulin, but it should be avoided in smokers, in chronic pulmonary patients, and patients with increased risk of lung cancer, because they can result in cough, throat irritation, pain, and decline in the FEV1 in spirometry. So that is one problem associated with the inhaled insulin, Afresa. And this is the Afresa inhaler. You can see here we have the Afresa inhaler, and the cartridges are there with 4 units, 8 units, and 12 units. Warning is the box warning is that acute bronchospasm seen in patients with chronic diseases such as asthma or COPD, the chronic obstructive pulmonary disease. The patients, if they take Afresa as an inhaled form, they may suffer acute bronchospasm. That is the warning given for Afresa. So that is about the inhaled insulin. Now the scientists are working on the oral insulins nowadays. We have one insulin tregopil. It's a ultra fast acting analog insulin tregopil. It is in the pipeline, completed phase 2 and phase 3 trials. And the mechanism is that they are stimulating the ornithine decarboxylase, phosphokinase stimulants, protein tyrosine kinase, is mimicking the action of insulin. And that, remember the name, insulin tregopil. Okay, it is in the clinical trial phases, and it's a promising one. The formulation is available in the tablet forms, and it is given 10 to 12 minutes prior to the major meal. Improved half-life, digestive tract, and improved absorption happens. So that is about insulin tregopil. We have oral buccal spray formulation of insulin for type 1 and type 2 diabetes, approved in Ecuador. It is in the clinical trials. It is absorbed from the buccal mucosa in the mouth. Oralin, tregopil, oralin. Oramed is in the phase 3 trials for type 2 diabetes, or it's a capsule. Okay, Oramed is a capsule. So the mechanism of action, it is that facilitate uptake by inhibiting the proteolysis that happens in the GIT if you take insulin, just like that. So this capsule prevents that proteolysis and improves the translocation of peptides across the gut epithelial lining into the systemic circulation. So they are associated with the capsule and also have permeation enhancers, which helps in the permeation across the gut epithelial lining into the systemic circulation when they are taken orally. These are some of the mechanisms how they can evade the digestion by the intestines and the stomach. So, they are 16 milligram once weekly dose is given for Oramed. It is still in the trials. Then there is icosema. It's a combination of icodec and semaglutide. That is the term icosema came into being. Icosema. It's a once a week subcutaneous injection that is currently in the phase 3 trials. Icosema. Semaglutide is a GLP-1 receptor analog, which is an oral anti-diabetic injectable. And nowadays we have the oral form of semaglutide also available. Usually GLP-1 RAs are injectable forms only, but semaglutide we have the oral form also. That's for another area of discussion. But icosema is a combination of insulin, icodec, and semaglutide. So this is the trial which is shown that combined three trial is showing promising results about icosema. And coming to the end of the discussion about the insulins as such, we can finish it off with the insulin delivery devices. We have the pre-filled syringes. You are all aware of that. Then we have the insulin pumps, infusion pumps, and they are developing artificial pancreas also. So these are the insulin delivery devices available to deliver the insulin as subcutaneous injections, as subcutaneous infusion, and artificial pancreas. Now, as a doctor, we will be seeing a lot of regimens using insulin analogs. So, one regimen is the basal regimen, in which the long-acting insulin glargine once daily it is given at bedtime, or detamar, which is given twice daily, and may be used when starting insulin in type 2 diabetes as a starting insulin in type 2 diabetes, along with oral anti-diabetic agents used when there is dependence on other injections. So, this is the basal insulin regimen. Only basal insulin is given, especially the Lantus or the insulin glargine is nowadays used. It can be used as a starting insulin when the type 2 diabetes patient is requiring an insulin in a further stage of disease. You can start with insulin glargine. Then we have the split dose regimens, very famous premix analogs injected twice a day, pre-breakfast and pre-evening meal in type 1 and type 2 diabetes patients, which simplify the dosing and decreases the number of injections. Okay, we are mixing it with the rapid acting and a intermediate acting or long acting insulin, and it is injected twice daily before breakfast and before the night meal. Nowadays, another famous regimen is the basal bolus regimen, which is in which the glargine at bedtime is given to cover the basal insulin secretion, and we will give a short-acting analog during the mealtime glucose surges. And it is usually given in type 1 patients and in type 2 also sometimes. Analogs are preferred in intensive regimen due to decreased risk of hypoglycemia with their use. So if you remember, you can see that insulin Lispro, Aspart, and Glulisin were the insulin analogs which are having a low postprandial hypoglycemic episodes compared to the regular insulin. This can be used as the bolus regimen. Using the bolus regimen and basal insulin, we use glargine usually at the bedtime. So these are the three regimens you have to remember: basal regimen, conventional split dose regimens, and basal bolus regimens. Now we have the insulin pumps. Most physiological method of insulin delivery is by nowadays it is the insulin pumps preferred in patients with uncontrolled and multiple injections required patients, pregnant patients, and especially suitable for patients with risk of hypoglycemia, uncertain lifestyles, uncertain meal times. Okay, so they may be forgetting to take their insulin shot, insulin jab at the correct period of time, and they may even forget to take the food at correct period of time, so they can use this insulin continuous subcutaneous insulin infusion pumps. Consist of insulin reservoir, program chip, keypad screen. Insulin is infused through a plastic tubing connected to subcutaneous inserted infusion set. So insulin delivery, we use the short-acting insulin analogs like Lisproaspart is used in the pumps, provides constant basal infusion of insulin, and patient can activate the pre-meal boluses if wants. Pumps can be discontinued for short periods for activities like exercise. You can stop that if you want. Pump can be pre-programmed to compensate for nocturnal and early morning glucose fluctuation. So advantages, the rate of insulin absorption is more predictable than multiple injections during the day and night, and risk of hypoglycemia is less. Drawback is that if at all the pump is failed, that can resulting in the dangerous diabetic ketoacidosis. The insulin site abscesses can have very rarely, and motivated and committed patients are required to use it. In special situations, we can use insulin analogs as IV. Usually, I told you that approved IV form is the regular insulin, but in certain conditions, such as in diabetic ketoacidosis, Lispro may be used as IV in pregnancy, in children, and sometimes in elderly at the risk of hypoglycemia. Insulin analogs are preferred in children. Data on insulin analogs are limited. We have insulin pens for ultra short acting, long acting premix analogs, newer insulin pens, and newer continuous subcutaneous insulin pumps are there. And we can sum up the merits of insulin analog. We can see that they better mimic the physiological insulin secretion, better have postprandial control of postprandial blood glucose levels, better control of the glucose levels in the fasting in the digestive period, lesser risk of hypoglycemia, action profile independent of dose, and more predictable, greater flexibility with short-acting insulin as they can be given at meal time. So this is the some of the advantages of insulin analogs when compared to our regular insulin. But these insulin analogs are costly when compared to our regular insulin. So that is one thing. And there is worsening of retinopathy seen with the Lispro. That is one problem. And they are sometimes they are concerned with carcinogenicity also, but not proved yet. But significantly, the adverse effects are low when compared to the standard insulin. Only the cost value is the main problem here. Coming, so that's the end of the insulins. Now let us see what are the adverse drug reaction of insulin. So most dreaded one is the hypoglycemia, isn't it? The patient may have tachycardia, confusion, vertigo, sweating, or the diaphoresis, hypersensitivity, lipodystrophy on a long run. All some these are the some problems associated with the use of insulin in patients, and if they develop hypoglycemia, they can manifest with all these symptoms, and we can manage it. In the mild case, we can give glucose. When the patient is having these kinds of symptoms, suddenly we should advise them to take glucose orally. And if the patient is not able to take orally, or the patient is unconscious, glucose can be given as IV, slow IV infusion. So that will help the patient to recover from the hypoglycemic episodes. Then we have the local reaction at the injection site. Sometimes lipoatrophy or lipohypertrophy can happen. Allergic reactions, especially with the conventional forms of insulin, edema, obesity, and rarely hepatomegaly. Drug interactions of insulin is also important. We have to remember that certain drugs, if you are taking patients with elderly patients, may have multiple drugs for the different conditions along with insulin. If they are taking propranolol, which is a beta blocker, it can result in unawareness of the hypoglycemic symptoms, and the patient may not have the hypoglycemic symptoms because of the beta blocking property, and that can result in delayed recovery from the hypoglycemia. Patient may not have the classical features of hypoglycemia that may prevent the patient from taking glucose at correct period of time of hypoglycemia. Salicylates, lithium, theophylline, etc. increases the insulin release. Again, when they increase insulin release, chance of hypoglycemia increases. Alcoholic patients, if they're taking insulin, there is chance of depleting her glycogen storage. Again, chance of hypoglycemia results. Diuretics, thiazides and loop diuretics, corticosteroids, oral contraceptive pills, calcium channel blockers, beta 2 agonists, and increases the blood glucose levels. So that the efficacy of insulin, if they are taking, that can be decreased by these drugs, steroids, OCPs, calcium channel blockers, diuretics, etc. These are some of the very common drug interactions that can happen with the patients who are taking insulin. Okay, so are you okay with all these side effects and the drug interactions of insulin? We will just finish our presentation by recapping the main features of insulin. You remember the definition of diabetes. You know the different types of diabetes: type 1, type 2, monogenic diabetes, and gestational diabetes. Then you saw how the diabetes is diagnosed using different criteria. Insulins, you saw how it is discovered, who discovered it, who got the Nobel Prize. You also saw the different classification of insulin, that is into the rapid acting, short acting, intermediate acting, and long acting insulin. You also saw ultra long acting insulin, the gludec and icodec, and nowadays we have ultra fast acting analog insulin, tregopil, which can be given orally sometimes. And we saw the inhaled insulin, Exubra, which is discontinued, and we have the Afresa nowadays, which is inhaled insulin. And we have so many other oral insulins in the pipeline. And you also saw the mechanism of action of insulin. Whenever the insulin comes and binds to the insulin receptors, it can result in different actions, especially the mitogenic action resulting in the cell proliferation and cell growth. And also you have the metabolic actions. And insulin is given in different regimens. You saw that also. Adverse drug reactions of insulin also you saw, especially the hypoglycemic episodes. Dreaded complication. Always remember, hypoglycemia is deadly. Hyperglycemia is dangerous, but hypoglycemia is deadly. And insulin is usually given subcutaneously at the lower abdomen, upper outer arms, upper outer thighs, and buttocks. So these are common areas where insulin is taken, injection sites for insulin. And that concludes our presentation for today. So thank you so much for your patient listening, and the session is open for discussion. You can come up with your concerns, or if you didn't understand any part of the presentation, I can explain that to you again. Okay, thank you so much. Insulin is a very big topic, but this gives you an introduction to the insulin. So you can build upon these points. It will be helping you in your examination, definitely, and also in your practice. If you want any further information on this topic, you can contact Med Institutors. They will help you. Yeah, thank you so much.